My question is really based on this natural affinity and this partnership that is growing and developing between India and the UK. What is its nature in terms of knowledge transfer, each system benefiting the other? You know, you did identify that the UK healthcare system is currently lacking in, well, the big issue we have here is in aging and chronic diseases and that population increasing. And that's rightly in India as well, as Professor Taylor pointed out. So what are we looking at achieving? Is it more of a universal healthcare or a synergistic relationship? Because a lot of the problems in India are mirrored over here and vice versa. Yeah, so and I appreciate it's a big answer.
Yeah, so I think it is the fundamental question in terms of relationships between the United Kingdom and India in healthcare. You're quite right to emphasize the fact that both systems face a onslaught in terms of the resources that are going to be required to care for aging populations with chronic diseases and multiple comorbidities. And what's been very interesting in India is there have been some very innovative models that have demonstrated to us how we can do things more efficiently and more effectively and deliver high-quality care to large numbers of patients. And one of the interesting models is the eye care centre model that we've heard about this afternoon. But going forward, I think where there is a natural starting place in terms of relationships between the medical and healthcare communities in the two countries is in the area of education and training. Because it's not as simple as saying, well, UK institutions can go and train in India, and of course that I think will be very welcome and it will help address capacity gaps through know-how and the ability to develop programs of undergraduate and postgraduate training being delivered locally in India. But also there have been and there will be increasingly important opportunities for those who are training in the United Kingdom to spend time in India and to learn from the healthcare system there, because there is so much innovative practice and a fresh way of looking and addressing these types of challenges. But I think what's most important is there's a recognition between the two countries and the two healthcare communities that there are shared problems and that they're very interesting models, not necessarily driven purely by the public sector or driven purely by the private sector, but also in between the kind of ideas and concepts of providing the basis for these to happen through different funding models that are very, very exciting. But they're also very, very big challenges because there are big regulatory hurdles in both countries that need to be overcome if both countries can work together effectively.
Well, can I ask, I don't know, Professor Taylor, in meeting that challenge, do you see that the challenges or the problems are shared between the UK and India, or do you feel that there are important differences?
I wonder why it calls me Professor Taylor. I'm looking for the sting in the tail of that.
Turner, sorry.
No, it's David, I mean. There is a danger in overestimating and exaggerating this effect of population ageing. Sure, as one gets older, the rate at which one's likely to develop to chronic disease is higher. But as we have development processes, by and large, the age at which disability starts moves back as life expectancy increases. One of the problems, I think, in India is that the advantages of population ageing and keeping us all healthy longer and having communal health services, which we did do quite well in the NHS, haven't been fully realised, and that's a different issue. This under-expenditure in public health services. I certainly agree about social enterprises being wonderful as showing you examples of what you can do. But sustained public provision to poor populations especially, and by and large it's good to keep us in the same boat, all the evidence is clear, means that there are real differences in the nature of problems. Having said that, how do you keep populations healthy, wealthy, and keep healthcare costs down? You invest in primary care, even in the UK. We're underusing medicines like antihypertensives. We're grossly underusing them in India. How do we drive up healthcare costs? by very expensive medical interventions towards the end of life in those palaces called hospitals. I disagree with you about we've got too few hospital beds. We need to focus on the really effective use of technologies, remembering that public health is also a function of the degree of class difference in societies. It's a function of clean water, it's a function of good food. Health and medical care and pharmaceutical care are a small part, but they can make a difference today.
Okay. So prevention to help reduce cost in the long run?
Prevention and treatment in primary care, low-cost settings for the mass of the population, rather than expensive settings for old blighters like me, who close to the end with something completely ghastly.
There's another question here. Now, I know that we are between you and a coffee. We started a few minutes late, but certainly we'll have this question and see where we're at. There's a question.
Thank you very much. I'm Bina Rawal. I work for the ABPI, which is the British Pharmaceutical Industry Association. I wanted to ask David whether he thought that the rapid growth in the generics sector in India has to some extent deterred the innovative R&D potential of a country such as India, which has magnificent life science institutes, and there isn't a tradition of taking that forward into innovative R&D in the pharmaceutical space, where the focus is very much on generics.
I think it's great that the Indian industry, after the Brits had not developed local industry at all and had controlled importing, so you only got second-class Indian goods, or British goods when you could have got good Indian goods, or perhaps even better German goods, was a disgraceful episode, and India's done stunningly well in the last half-century developing its generics industry. There's certainly a great role for that. Whether or not then there's a very different thing from saying frugal research where you're developing an existing technology, producing it more cheaply, presenting it more effectively, where the actual risk on the capital employed is very low, to the mindset which is about investing, depending on how you do the accounts, hundreds of millions of pounds, thousands of millions of pounds, in genuinely high-risk research which can all go wrong. Partly there's the issue of the funding base, partly historically at the point where the Indian industry began to develop its innovative capacity, and it's there, the game became very much harder. So I think there's also a chance of history. I wouldn't like to criticize the generic industry. I would say, though, that unless we have good intellectual property protection, nobody's going to invest that money you need, whether it's in future in India, or in the UK, and the States. If we destroy that system, it will be terrible. But at the same time, in the past, we haven't been good about making sure the poorest get access.
Now, I know that we're pushing against the time. I'm very tempted to take one more question, and I think then after that, perhaps if people have questions, we can deal with them over coffee. But one more from the floor.
This is for Professor David Taylor.
Sorry.
The same subject, which is very controversial, I think, is where exactly and how exactly do you draw the line between the healthcare need for developing country nations and respect for patent life?
I don't think it's difficult. I think other colleagues should talk, but very quickly. A classic mistake is to think about the value of drugs in the substance. Gold, as we all know in India, is deeply valuable because it's scarce and we think the stuff itself is the value. With most modern drugs, the relative production cost is quite low compared with the investment in the thought, in the clinical trials, in the development, all the other, and the risk capital, the money which went on all the failures. So when we do have a technology, classic welfare economics would say, well, the marginal cost of production is relatively low, even if it's a big biological molecule. We can do it, we can supply it, providing we don't destroy the whole market. So it is eminently doable, but it depends on that understanding that the value of the drug is not in the substance, it's in the ideas, and it then depends on differential pricing and respect for market segmentation. It's a difficult argument. You can't communicate it in a few sentences easily. You certainly can't communicate on television, but I think it's true. But would you agree?
Well, it's not an area where I have the expertise that you have, but I think what you've described seems eminently logical. At the end of the day, for innovation to proceed globally, which is what innovation in healthcare and the life sciences is, it's a global enterprise. It's not the enterprise of a single country. the kinds of protections that that type of innovative work requires to be sustainable need to be respected. But equally well, there must be the opportunity to find models by which that innovation can be provided in different healthcare systems and different health economies.
So we have a panel session after the break on innovation, and I think maybe some of these issues can be explored a little bit further then. But I'd like maybe to thank our panel in the usual way. Thank you.